alveolar. The distribution is important. These wordings are very important in chest imaging. You should always use these wordings. Associated findings, you should look at the review areas. But if you see a major abnormality, just try to wrap up the case as soon as possible. You were taking some more time in discussing these pathologies, and you can use these wordings. Like, I like the way you said, in my routine practice you will review the clinical information, you will review the prior imaging, and you can do the MPR, you can do the MIP imaging, mediastinal and bone window settings, you will review them and try to include or exclude differences while you describe them. Raise alert for an emergency finding, call the clinician, raise an alarm, and you should discuss about the management pathways, MDT, referral, further workup like lung cancer. We have already discussed this, what we are going to do. Give me a second. Okay, I'm sorry, I'm on call as well. I received a call from the hospital. So we have discussed these things. So these things are really important in UK for the chest imaging. There are certain things which I would like you to focus on, which are BTS guidelines. You should know about these BTS guidelines as well. If a nodule is less than 5 millimeter in size, we don't do any follow-up in the absence of primary lung malignancy. Okay, so if there is a primary lung, in absence of any primary malignancy, if there is a malignancy, so we can do follow-up. If there is no malignancy at all, there is no history of malignancy, no known malignancy, then we don't follow up for lesions which are less than 5 millimeter in size. Okay. Then we have different approaches. We follow up it up to 3 months initially, then we follow up at 1 year interval. Okay. For subsolid nodule, we can follow up it up to 4 years because sometimes they can develop into a slow growing adenocarcinoma. So BTS guidelines are really important in UK and you should know about them. Any question may or may not be asked about them, but if you want to practice as a radiologist in here in UK, you should know about BTS guidelines uh, for the lung cancer treatments. Okay. Okay, so this is for the MR imaging. You can be shown multiple, you can may or may not be shown some cases of MR imaging, but this diagram is really important. So if there is a subendocardial enhancement pattern or a transmural enhancement pattern in a vascular territory, then it is an ischemic pattern of enhancement. So any pattern which is apart from this pattern, like a mid-wall pattern, it is a non-ischemic pattern of enhancement in cardiac MRI. So this is kind of a cheat code in MRI. So if they ask you what one sequence that you would like to see on a cardiac MRI, it should be a late gadolinium sequence, and you should look at the enhancement pattern. So there are some cheat codes, there are some guidelines that you need to follow in cardiothoracic imaging, and you should know about them. Okay. Okay, now moving towards the case 3. Candidate 1, are you with me?
Yes, sir.
I'm sorry, I'm showing all the cases to you. I think we have covered that, but okay, just let me show you. I was told to show some cases of intervention as well, so that's why I'm showing you these cases. So this is how we do a CT guided lung biopsy here. This is our marker. Okay, we place this marker and scan the patient, and we can see the lesion here, which is a big solid lesion. Okay, then we will give some local anesthetic, and uh, then we will insert it. This is a coaxial needle, so all the lung biopsies are coaxial biopsies that we biopsy through a needle. Okay, so we place the needle inside it, and then through that needle we will place the biopsy needle, and we'll take course from this lesion. Okay, so this is how we do a CT guided lung biopsy in UK or in any other part of the world. Okay, so this I would like. Okay, so I will show you. I'd like to show you one more case as well. So here is your case. So cough for few months, current smoker, no other past medical history, 60-year-old female patient. Here is the chest X-ray.
Sorry. I'm provided with X-ray frontal projection X-ray chest of a patient. Sorry, sir, I was not able to hear the age of the patient you just provided.
Age is 60-year-old
Cough,
female. Yeah.
cough, smoke. Okay. Uh, there is a well-defined, there is opacification of right lung mid zone with obliteration of right CP angle. Right heart border is well visualized. So I assume this opacity lies in, uh, this opacity is probably in the anterior mediastinum. I see the slight mediastinal shift towards the right side. I cannot see the pulmonary vessels through it, or the pulmonary hilar markings are obscured basically. So that is that shows that this is a middle mediastinal lesion with obstruction of right CP angle consistent with associated minimal pleural effusion. Uh, underlying um, underlying fibrosis must be there, which is leading to the shifting of trachea towards ipsilateral side. I cannot see any associated nodules in rest of the lung parenchyma. As the patient is smoker, and I will be concerned about any primary lung lesion and would investigate this patient further with contrast enhanced CT chest to look for underlying pathology. I'm provided with, um, I will be requesting the remote control cell. Axial section of the same patient, lung window. I see that there is a thick wall. Sir, can I see the mediastinal window?
Yes, but you need to first comment on this. Then we will.
And there's a thick walled cavity in the right posterior. Uh, it's in the apical lobe basal lung in the on the right side with associated minimal ground glass haze interjects lung parenchyma. This cavitatory lesion shows internal air fluid level and it has ill-defined margins. My primary concern would be a sinister pathology like primary cavitatory lung lesion, and um, I would also concern. I am looking for any pulmonary nodule in the contralateral lung. I would be looking towards mediastinal window to look for any underlying lymph enlargement. I can see an enhancing mass-like area involving right lower lobe bronchus, obliterating it completely, lying just adjacent to this cavitatory lung lesion. This could be a primary pathology or a bronchial mass. I'm looking for any associated hilar lymphadenopathy. This lesion in is reaching up to hilar area. No associated lymphadenopathy I can see. So in
So
summary,
what?
this is an yeah. In summary, it's a hilar mass, a right-sided hilar mass with associated cavitary pulmonary lung lesion. It looks like a malignant pathology. I will inform my findings to the clinician and would arrange uh, a staging CT for this patient. Would refer this patient to MDT after staging, and if this patient is amenable to endobronchial biopsy, would arrange an endobronchial biopsy after MDT.
ओके गुड ठीक है आप एंडोब्रोकियल बायोप्सी नहीं अरेंज करते बहुत कम रेडियोलॉजिस्ट हैं जो एंडोब्रोकियल बायोप्सी करते हैं हमारे हॉस्पिटल में एक हैं लेकिन ज़्यादातर हम लोग परकुटेनियस ही करते हैं हम एंडोब्रोकियल नहीं करते तो ये this these are the PET images you forgot the PET so these are the PET images can you scroll
Okay, that
so there are multiple PET
this.
images we usually look at the axial fused PET
Hmm,
images okay, so these are the
hmm,
axial fused PET images so CT scan is fused with
hmm,
the PET images so
hmm. So I'm provided with a PET CT fused images of the same patient, and I also see that there is increased uptake in the above previously mentioned lesion on the CT scan, confirming my diagnosis that it's a mass lesion, which is a hilar in location with an associated cavitary lesion. Um, the uptake on the previous on the posterior aspect of the cavitary lesion is likely reactive. I don't know those are exactly terminology what has to be used for this area of uptake, but I know that this is not pathological uptake with respect of the cavity. The anterior uptake is conforming to the lesion and is the actual site and size of the lesion can then be measured through the adjacent CT images.
very good. So you can see that there is an avid uptake anteriorly. छोड़ दें CT को मैं
Okay,
scroll.
okay.
So you can see that there is an avid uptake anteriorly more towards the hilar region, which is the actual tumor. So these are probably some superimposed infection or some other surrounding changes. This is the actual tumor. It is very
Mhm.
intense uptake, so it is very close to the bronchus, and they can do an endobronchial sampling in that. We can approach this lesion from here, and it will lead to the sample will be non-diagnostic. It won't turn out to be tumor, and it will be a false negative biopsy. So if they do an endobronchial approach, it will there will be more chance of having a diagnostic sample, and this through endobronchial approach, it turned out to be a tumor as well. So this is the utility of PET CT scan. So you can it also helps you in deciding the biopsy, and it helps you in T staging as well. So if you are reporting a CT scan, you will stage it as per CT size, which will be wrong eventually. It should be staged as per PET size. Okay. So now moving back to my presentation, we have covered multiple cases and we have talked about these things, but I would like to discuss a couple of things. So in PET, we talk about FTG uptake, okay, and we talk about SUV. So SUV is the values like in CT density, we talk about Hounsfield units. It is the same as in PET. It is SU standard uptake value, standardized uptake value. We compare it with the mediastinal value. We measure the mediastinal uptake value, which is usually we measure it in ascending aorta, okay, which is the reference point, and then we compare it to the SUV value of the lesion. Okay. So usually the mediastinal value is around 0 to 2.5, okay, which we call it equal to mediastinal blood pool, and it is low intensity. The moderate intensity will be 2.6 to 5, okay, which is raised but moderately raised. If the intensity is more than 5, then we say that it is SUV is more than 5, then we say it is high intensity, highly avid mass lesion. Okay. So usually highly avid mass lesion can be a malignancy, or it can be an infection as well. Okay, and usually for highly avid lesion, we go up and we do further investigation and things like that. Okay? And they can be very high intensity, like more than 10 as well. Okay, you should know about the physiological uptake in PET CT scan. Some areas may show physiological uptake. So if there is some fat, is if there is there is an uptake in interatrial septum. Sometimes it is due to fatty replacement of the interatrial septum due to lipomatous hypertrophy of that. So it can be avid on PET, but it is physiological. It is normal. So that's why you have to look at the CT imaging as well before deciding everything on the PET scan. Sometimes there can be no uptake in the heart, and sometimes there can be uptake in the left ventricular walls, which is ring-like uptake, which is normal pattern. It is not pathological. So you should know about physiological tracer distribution in the body of PET CT scan as well before reviewing the PET CT scan. Sometimes bone marrow can have some increased uptake secondary to smoking, and sometimes increased uptake secondary to drugs as well. Okay, so you should know about these things before approaching the PET CT scan. Okay, so this is how PET helps you in lung cancer. It might show an avid uptake. We document the SUV value as well. What is the SUV max of that lesion? It is 5 or more, so it is more diagnostic of a malignancy. Still, it can be an infection as well. So I repeat again and again, PET is sensitive investigation, but it's not specific investigation. And in this kind of uptake, when the lesion grows and becomes large, it will surplus, or it will outgrow its blood supply. So it will have a central necrosis. So it will have a solid pod, it will have a cystic pod. That helps you guide your biopsy as well. So if then we should biopsy the avid part, the solid part of the tumors, to have it as a diagnostic case. Some of the lung cancer do not show any PET uptake. One of them is pulmonary carcinite, which is famous, and the other one is adenocarcinoma. So lung adenocarcinoma may or may not show any PET uptake. So if there is a lung adenocarcinoma, it is proven it might be negative on PET, and its metastasis will also may be negative on PET. So you should keep these things in mind. Okay, there are some exceptions to everything. So this was a summary about PET CT scan. I was told to discuss the PET CT scan. So um, now I will talk about some of the interventions. So candidate one, what do you think? What is this?
So this is axial section taken in the portovenous phase at the level of the liver.
Tell me the diagnosis, please. What's the diagnosis we are short of
So,
time?
there is air anterior to the liver and within the liver as well. So uh, some liquefaction has been done in the. So I don't know.
So
Maybe
it is a
maybe
liver
some.
abscess. Okay? It is a liver abscess, so which has ruptured. That's why there
Hmm.
is surrounding air as well. It also has cholecystitis as well. Due to cholecystitis, it developed a liver abscess. We have put a drain in the. It is a cholecystostomy drain here. We can put another drain here as well. So this is how we put drains. Okay, so if there is an inflammation, infection, or a collection, you need to put a percutaneous image guided drain as well. This is again a lung lesion biopsy. Here is a lesion. The safest approach is from the back. So we will prone the patient and will approach from the back side and biopsy the lesion. Okay. It might lead up into a pneumothorax. We try to aspirate it sometimes. If not aspirable, we may need to put in a chest drain. Like here, we have put a chest drain in it. Okay. So this is about lung interventions, lung biopsies, lung cancers. Okay, and the summary of the tips are that initially you should know about the Aunt Mini cases. Okay, you should know all the Aunt Mini cases by heart. You should not miss them in your exam. Your approach should be like a proper radiologist. You should have a logical, safe approach, a systemic approach while describing different pathologies in your viva. you should know certain things about PET CT scan. You should know certain things about intervention as well. But you may or may not be asked about them, but you should know these things because they are not usually taught back home in Pakistan. So I will share the feedback link. Are there any questions? Yes, feedback link have been shared. Can you please give me feedback on the presentation? It helps us improve our sessions. काइंडली एडिनोकार्सिनोमा वाला पॉइंट रिपीट कर दें. एडिनोकार्सिनोमा में यूजली ये होता है कि उसमें पेट सीटी पर अपटेक कम होता है, लो अपटेक होता है. दे आर यूजली दे कैन बी यूजली वेरी स्लो ग्रोइंग ट्यूमर्स. हमने शुरू में भी कहा कि हम they can be followed up to 4 years. If there is a ground glass nodule, usually follow it up to 4 years until we are certain that there is no cancer in it, because adenocarcinoma spectrum nodules, they can develop into cancers. They are very slow growing, and as they are slow growing, they have less metabolic activity. They are not pet avid usually. Okay, so that's why if we are suspecting adenocarcinoma in a patient, we will go and do the biopsy. We might go in and surgically resect the patient, and it will turn out to be adenocarcinoma, and it will not be PET avid. So these are the two exceptions of the PET. The lesions which are cancerous and which may not be PET avid. One is adenocarcinoma, the other one is pulmonary carcinoid. Okay. Difference between consultant on call and trainee on call. Trainee on call, जैसे कहा गया है, they should be in the department. I am consultant on call. तो यूजली हमारे यहाँ ये होता है कि ट्रेनी रिपोर्ट करते हैं, हम उसकी रिपोर्ट को देखते हैं और हम विद इन 12 आवर वी हैव टू वेरीफाई दैट रिपोर्ट. कभी कभी कोई ऐसा इशू हो जाता है पेशेंट के प्रोटोकॉलिंग की वजह से, आउट पेशेंट स्कैन भी हो रहे होते हैं संडे के दिन, तो उसके हवाले से हमें कभी कभी कॉल्स आ जाती हैं, तो हम वी हैव टू रिव्यू दैट. तो ट्रेनीज शुड बी इनसाइड द डिपार्टमेंट व्हेन दे आर ऑन कॉल, और वो वहाँ से रिपोर्टिंग करते हैं. मैंने ई आर ऑन कॉल्स भी की हुई हैं जब मैं यहाँ पर फेलो था, विच आर नॉट दैट फन. ओके, थैंक यू वेरी मच. फीडबैक फॉर्म प्लीज फिल कर दीजिएगा. अगर कोई क्वेश्चन है तो मुझे बता दें. आई विल बी एबल टू आंसर द क्वेश्चंस. थैंक यू फॉर अटेंडिंग द सेशन. थैंक यू वेरी मच. ये फीडबैक फॉर्म के लिए ये स्लाइड रहेगी, फिर उसके बाद 5 मिनट के बाद मैं सेशन खत्म कर दूँ. थैंक यू वेरी मच. टेक केयर. अल्लाह हाफिज. बेस्ट ऑफ लक फॉर योर एग्जाम्स.